Usually, when we talk about a new medical technology being introduced into clinical practice, there's this expectation of clear parameters.
Right, exactly. Like you expect a manual.
Yeah, think about engineering, right? You get a new MRI machine, and it comes with this massive manual. It has a strict protocol. The workflow is totally defined. You know exactly what it does and, well, who is allowed to push the buttons.
Which is exactly how we like things in medicine, to be honest. I mean, we want interventions to be categorized, visible, and, entirely predictable.
But then you step into the world of artificial intelligence in pediatric clinical decision-making, and suddenly all that neat packaging is it's just gone.
Completely gone.
We are looking at an implementation landscape that isn't just murky, it's practically uncharted territory at this point.
It really is like the absolute definition of clinical muddy waters right now. The tools are advancing so much faster than the infrastructure can even handle them.
Exactly. So welcome to the latest episode of Pathways in Pediatrics, the podcast of the European Academy of Pediatric Societies, or EAPS. Today, we are taking your stack of notes from the recent EAPS step-by-step webinar from June on AI in pediatrics, and we are extracting the vital nuggets you need to know.
And we have two amazing sources anchoring our discussion today. We're looking at presentations from Professor Alberto Tozzi, who is a pediatrician and innovation lead at Bambino Gesù Children's Hospital in Rome, and Dr. Yuri Ilan.
Right. Dr. Ilan is a pediatric hematologist-oncologist at the Princess Maxima Center in Utrecht, and he also spends time as a visiting faculty member at Google Research.
Which is such a unique overlap of skills.
Yeah.
And what makes these sources so compelling is that this isn't just, theoretical tech optimism.
Not at all.
It's about real-world implementation.
Yeah.
We are really looking at the true opportunities, the logistical nightmares, and how human judgment has to adapt when the machine in the room might actually process data better than you do.
Right. So let's start with where the medical community actually stands right now. Because, if you just read the headlines, you might think doctors are either entirely terrified of AI or actively rejecting it.
Right. But the data tells a completely different story.
It really does.
Yeah.
So Professor Tozzi opened the webinar with a live poll of the attendees, who are primarily practicing pediatric clinicians. And over 2/3 of them reported that they already use AI either daily or several times a week in their practice.
Wow. 2/3.
Yeah. And only 9% said they had never used it.
So the adoption it's already happening on the floor. But here is the fascinating part. When they asked this highly engaged group what the biggest barrier to AI adoption was, it wasn't a lack of interest, and it actually wasn't institutional pushback, which only scored about 6%.
Wait, really? Just 6%?
Yeah. The primary hurdle, the one that absolutely dominated the poll, was uncertainty about the reliability and accuracy of AI outputs.
That makes sense.
Right. I mean, they want to use it. They are using it.
Yeah.
But they are deeply anxious about whether they can actually trust what the algorithm is spitting out.
And to ground that need for trust in a real clinical scenario, Tozzi highlighted a specific case study involving a young boy named Mattia. So Mattia has congenital heart disease, and unfortunately, he suffered an acute kidney injury, or AKI, following a surgical operation.
And AKI is a severe, potentially life-threatening condition. But the critical thing about AKI is that it is often preventable if you can recognize the physiological signs very early. You really have to predict it before the cascade of damage begins.
But here is the massive disconnect they discussed. The intensive care unit where Mattia was staying is packed with monitors. I mean, they are constantly measuring heart rate, blood pressure, oxygenation. The data is just continuously flowing.
Right, gigabytes of data.
Exactly. But the hospital simply did not have the infrastructure or the tools to synthesize that massive amount of real-time data to predict the complication. They were swimming in data, but essentially starving for insight.
Exactly. They had the desire to use the data, but lacked the capacity. And what happened next is, frankly, wild.
Oh, yeah. This part is amazing.
Mattia's father, Davide, happens to be a physicist. He was working as a teacher at the time. And he actually completely changed his career. He became a researcher, spent a couple of years, and built an algorithm to predict AKI himself, specifically utilizing that ICU data for his child.
Wait, I have to stop there because this is an incredible story, but it's also kind of a massive indictment of the current healthcare system, isn't it?
It really is.
I mean, if a highly motivated parent has to literally quit their job and change careers to build a predictive model, It just highlights an absurd gap. It means hospitals are sitting on a gold mine of continuous data and just watching it pass by because they don't have the analytical plumbing connected.
That is precisely the takeaway Tatsi presented.
Yeah.
It exposes the reality that data collection is not the problem anymore. Synthesis is the problem.
Right.
If you don't have the algorithmic infrastructure to interpret the data in real time, its clinical value is severely limited.
And that systemic synthesis problem is exactly what Dr. Ilon's work at Google Research is trying to solve, specifically in the realm of pediatric oncology. If you look at the challenges faced by the International Leukemia Tumor Board, the bottleneck isn't a lack of medical literature, it's the sheer volume of it.
Right. Dr. Ilon pointed out that we have seen incredible progress with leukemia. First-line therapy overall survival is reaching around 95%.
Which is amazing.
It is. But the refractory or relapsed cases, the 5% where the standard treatment fails, those are highly, highly unique. Every single patient is fundamentally different at a genetic level.
Because at that point, you aren't just looking at basic labs. These patients undergo whole exome sequencing, RNA sequencing. You suddenly have a massive, highly specific phenotypic and genetic profile to look at.
Right. And the notes mention an AML patient, acute myeloid leukemia, who might have a specific NRAS mutation combined with CD33 or MEDI123 positivity. And what does that actually mean for a doctor trying to find a treatment?
It means they have to find a needle in a haystack of medical literature. But the needle is made of, 5 different specific criteria that all have to match perfectly.
Exactly. Dr. Ilon described the reality of trying to do this manually. You go to PubMed, which is essentially the search engine for medical research, and you try to search for those specific, multiple, actionable events.
And PubMed is great, but it's fundamentally a keyword search, right? It's like a giant digital filing cabinet. If you type in those exact mutations, it just looks for papers that contain those exact strings of text.
Exactly. And because of how complex these cases are, finding and then manually validating every single paper to see if the context actually matches the patient was taking Dr. Ilon 2 to 3 entire days per patient.
2 to 3 days just to search.
Yeah. You just can't scale that. He even tried just dumping the whole clinical case narrative into PubMed, and the system just broke. It couldn't handle it.
So to solve this critical bottleneck, Dr. Ilon partnered with 7 Google engineers from across Europe. And in just 3 months, they built a tool called Capricorn.
Capricorn is an open-source AI super search tool. And the reason it works where PubMed fails is that it uses vector search across 40 million papers.
Okay, let's unpack vector search for a second because that term gets thrown around a lot. Why is vector search revolutionary here compared to just a standard keyword search?
Well, think of keyword search as looking for an exact match of letters on a page. Vector search, on the other hand, uses AI to convert words and concepts into mathematical vectors in a multidimensional space.
Okay.
So it maps the actual meaning of the text. It understands that words like relapsed, refractory, and treatment-resistant all live in the exact same neighborhood conceptually, even if the specific letters are totally different. It understands the clinical context, not just the vocabulary.
Oh, that makes total sense. So you can input the patient's entire messy lab report, and Capricorn uses that contextual understanding to match the 40 million papers to the patient's specific actionable genetic events. But if I'm a hospital administrator listening to this, my immediate panic is patient privacy. You cannot just upload a kid's genomic data to a Google-built tool.
Which is exactly why Dr. Ilon emphasized the privacy rails they built. The data is entirely scrubbed to remain GDPR compliant.
Oh, good.
Yeah, if the lab report has a date of birth, Capricorn automatically converts it to an age. Personal identifiers are stripped out before the search even happens.
And the second crucial element for clinical trust they mentioned is that Capricorn is a glass box, not a black box. We always hear about AI being a black box where data goes in, magic happens, and an answer comes out, and literally no one knows why.
Right, and clinicians hate the black box. They need to see the work. Capricorn is a glass box because every single treatment recommendation it brings back is weighted by the journal's impact factor and the year of publication.
Nice.
And it links directly back to the source paper. You can click it and read the exact study it pulled the insight from.
But there are limitations, right? Which Dr. Ilon was very upfront about in the webinar. Capricorn only reads abstracts and open source papers. It does not read paywalled texts, which honestly is a whole different conversation about the accessibility of medical science.
Oh, absolutely.
And most importantly, he explicitly stated this is not a direct decision support tool. It is absolutely not meant to replace a doctor making a decision.
It is entirely a data gathering tool. Its
Yeah.
sole purpose is to help a clinician prepare for a tumor board.
So if you're sitting on a tumor board right now, this tool isn't coming for your job tomorrow. Capricorn is essentially acting like the most caffeinated, highly efficient research assistant ever created. It gathers and organizes the literature at a speed a human could never match, but it absolutely relies on the human clinician to make the final medical evaluation.
Exactly. It does the heavy lifting of discovery. But because Capricorn only gathers the data, the next logical step Dr. Island presented is where things get, honestly, slightly sci-fi.
Oh yeah, this part is wild.
He's looking at how AI might begin to mimic the clinical synthesis and debate that occurs after those relevant papers are found.
Yes, the AI tumor board. He shared that he is currently working with the company ML6 and the charity LifeArc to develop specialized AI entities.
Right, so in this project, they take the data gathered by Capricorn, create a custom knowledge base of validated papers, and then these separate AI entities actually discuss among themselves what the best treatment would be.
Hold on. AI entities actually debating each other.
Yes, you can have the AI filter the papers to debate the best overall survival rate given a specific toxicity profile. They cross-reference each other, and every single decision or idea they generate is backed up by the literature and linked to a specific study on clinicaltrials.gov.
That is fascinating.
The idea is that a human doctor can take that AI-generated debate back to the human tumor board to inform the actual decision.
Okay, but seeing AI mimic complex clinical debate inevitably brings up the whole will AI replace doctors conversation. And this is where we have to talk about that graph Dr. Allen shared from Google Research, because frankly, looking through your notes, this performance graph just stopped me in my tracks.
It is a very sobering piece of data. Google tested medical performance across 3 groups: AI operating alone, human doctors operating alone, and human doctors using the AI tool.
And the results are completely counterintuitive. The AI alone performed the best. The doctors alone performed adequately. But the doctors using the AI actually performed worse than either the AI or the doctors independently.
It's a massive paradox. The combination of human and machine was less effective than the machine operating completely on its own.
Wait, how is that even physically possible? I mean, does this suggest that when clinicians use AI, we might inadvertently inject our own human biases and ultimately downgrade the AI's effectiveness?
That is exactly the core of the issue. It strongly implies that our human interaction with these tools is deeply flawed right now.
Yeah.
It could be ego, where a doctor overrides a correct AI finding,
Sure.
or it could be automation bias, where the doctor gets lazy, stops thinking critically, and just accepts a rare AI hallucination without checking it. Or it might just be terrible prompt engineering doctors simply not knowing how to ask the tool the right questions so they get bad answers and act on them.
So the tool is brilliant, but the user interface, meaning the human brain, is currently the bottleneck.
Exactly. Dr. Island looks at that graph and doesn't see AI replacing doctors. He sees an urgent, glaring opportunity for us to learn about our own biases.
Yeah.
We have to learn how we are actively degrading the AI's performance so we can actually use these tools to amplify our capabilities instead of dragging them down.
And, learning to use them brings us right into the logistical reality of the hospital floor, because Professor Tatsi really shifted the tone to deliver what he called the bad news.
Right, the reality check.
Yeah, the immense logistical and legal nightmares of actually implementing these algorithms in a hospital setting.
He stressed that before you even begin dreaming of AI tumor boards, you have to look at your local data.
Yeah.
Real-world clinical records are notoriously unbelievably messy.
They aren't clean, structured data sets at all. They are filled with missing fields, coding errors, typos from exhausted nurses, and massive variations in language and shorthand between different clinical centers.
Which means you cannot simply buy an AI model trained on clinical data from a hospital in Boston and assume it will perform the exact same way on your patients in Rome or Utrecht. The algorithm requires rigorous local validation.
And even if you validate it locally, Tatsi brought up this concept of data drift, which is super fascinating. Data isn't static, it's dynamic.
Right. Think about radiology. Let's say you train an AI to detect bone fractures using images from your hospital's current MRI machine. Then, next year, the hospital buys a brand new upgraded scanner. The contrast is slightly sharper, the pixel density is different.
To a human radiologist, the new image just looks a bit better. They adapt instantly.
But to the neural network, the fundamental mathematical matrix of the input data has completely changed. That is, data drift, the algorithm's performance might completely break down just because you bought a new camera.
Wow.
This means hospitals have to set up continuous monitoring via dashboards and employ dedicated teams just to constantly reevaluate the algorithms.
And that completely redesigns the hospital workflow. If you integrate an AI for detecting fractures, you have to rewrite the hospital rulebook. Does the AI count as the first reader? Do you still need a human for the second read?
Exactly.
What is the legal protocol if the AI says it's a fracture and the human doctor says it isn't? Who is liable?
And while administrators are trying to figure out those top-down rules, another completely chaotic operational challenge is emerging from the bottom up. During the Q&A, they discussed the concept of vibe coding.
I love this term. Vibe coding.
It refers to the new reality where, because AI language models are so accessible, regular doctors and nurses can literally use AI to write code and build their own local AI tools to solve specific inefficiencies on their floor.
Which is brilliant, but also kind of terrifying. You were talking about a sleep-deprived third-year resident at 3 a.m. using an AI chatbot to write a Python script to triage patient data because they are annoyed by the hospital's clunky legacy software.
Exactly. Dr. Island pointed out that on one hand, this is a beautiful democratization of knowledge. It allows under-resourced centers to build custom tools without needing a $1 million IT budget. But both speakers acknowledge this creates an absolute Wild West scenario in the hospital.
Right, it desperately needs regulation. You cannot have shadow IT systems running patient data based on vibe coding, but you also don't want to regulate it so heavily that you stifle that grassroots innovation.
Which zooms us out to the massive overarching regulatory landscape. Professor Totsi discussed the complex challenge of data sharing, especially looking ahead to frameworks like the European Health Data Space, which is slated for 2026.
Because to build the really powerful tools, especially for rare diseases like pediatric oncology, you need massive data sets. You need hospitals to share their data with each other. But historically, hospitals hoard their data like dragons hoarding gold.
They are incredibly hesitant to share. There's a massive tension here. We urgently need data sharing to train these technologies. But navigating these strict privacy regulations like GDPR, the new AI Act, or IPEA in the US, is a total minefield.
So how does a hospital practically reconcile this? I mean, how do you share high-quality data to power these tools while maintaining airtight privacy? Tassi noted that there are technical workarounds like federated learning,
Right.
where the AI model travels to the different hospitals to learn, but the raw patient data never actually leaves the local servers.
But even with technical solutions, implementing them requires huge multidisciplinary teams. You need clinicians, legal experts, privacy officers, ethicists. There are no fixed manuals yet, though groups like the Coalition for Health Artificial Intelligence are trying to develop playbooks. But Totsi's main argument was that this governance must ultimately be led by medical doctors, not just software engineers, because the clinical context is what matters most.
Absolutely. And, as all these workflows undergo these massive disruptions and these tools become democratized, the webinar addressed a very fundamental, almost existential anxiety that I know a lot of clinicians listening right now feel. Will relying on AI cause us to lose our foundational clinical skills?
Yeah, this fear was specifically raised by a participant who was worried about medical students. If a student can just plug a complex patient presentation into a medical AI and get the differential diagnosis in 2 seconds, will they stop thinking critically? Will they lose the ability to solve the case themselves?
It feels very reminiscent of the classic middle school math teacher argument, right? You need to learn long division because you won't always have a calculator in your pocket. Except now, the calculator is a supercomputer that has read every medical journal ever published.
Professor Totsi actually shared his experience running local simulation exercises with young doctors to test this exact fear, and he found something pretty reassuring.
Oh, really?
Yeah, he noted that young doctors very quickly realized the danger of over-relying on AI without critical evaluation. They learned fast that if you just ask an AI a complex clinical question and blindly accept the first answer it spits out, the clinical value is basically zero. It will hallucinate or it will miss the nuance.
So the true utility isn't using AI as an answer machine. Totsi advocated that we need to use AI to explicitly challenge our own mental models. You use it to force yourself to consider blind spots or rare possibilities you might have missed, expanding your thinking rather than replacing it.
Exactly. He even mentioned that early on, his innovation team hired a data scientist and a 3D printing architect, emphasizing that doctors need a highly open, multidisciplinary mindset to adapt.
And Dr. Island actually framed this fear of de-skilling from a much broader philosophical perspective. He pointed out that human evolution has always involved losing certain skills to gain new, more advanced ones.
Right. He used the analogy of riding a horse. We lost the collective ability to ride and shoe a horse because we developed cars and airplanes. We lost a hyperacute sense of smell because we developed other evolutionary advantages.
Exactly. He argued that integrating AI into medicine is just another step in that evolutionary chain. We might lose the ability to manually memorize and recall 1,000 different drug interactions, but we gain the ability to synthesize genomics in seconds.
The primary challenge we're facing isn't the evolution itself, it is the incredibly rapid whiplash pace of this specific transition.
So ultimately, both Professor Tatsi and Dr. Illen reached a strong consensus here. Trying to ban these tools in medical schools or hospitals is just a fool's errand. Instead, there is an urgent need to establish a medical education task force tailored specifically to the AI era.
The educational focus has to completely shift.
Yeah.
We no longer need to heavily index on training the next generation on how to memorize and retrieve facts. We need to train them on how to critically evaluate, rigorously challenge, and safely implement the outputs that AI generates.
As we wrap up this episode, I want to leave you with a final thought that builds directly on Dr. Allen's point about evolution. If we accept that we are going to inevitably lose certain traditional diagnostic skills to the sheer efficiency of AI if we are no longer riding the horse, so to speak, what are the entirely new clinical skills that you and the next generation of pediatricians will need to develop to effectively communicate with and critically oversee your AI counterparts?
That's the real question. Will the most important clinical skill of the 2030s be statistical skepticism? Will it be prompt engineering? Or will it be a renewed hyper-focus on the purely human elements of medicine, like empathy, complex communication, and holding a family's hand while explaining the AI's findings?
It completely reframes the future of medicine from a fear-based question of replacement to a proactive question of necessary adaptation. Now, if you want to explore the source material yourself, we highly encourage you to watch the full recording of this June webinar. It is freely available for you to revisit on the EAPS UNLOK educational portal.
And we warmly invite you to continue this critical conversation in person. Please join us at the next EAPS Congress in Athens, taking place from the 24th to the 27th of September 2026, where both Professor Tazi and Dr. Along will be speaking.
Thank you for joining us on this episode of Pathways in Pediatrics. Wishing you well, and we look forward to exploring more clinical insights with you soon.